I'd like to introduce on the topic of overview of PADS nationally, Marvin Swartz, professor and head Division of Social and Community Psychiatry at the Duke University School of Medicine. Marvin also runs the National Resource Center on Psychiatric Advanced Directives. Marvin.
Well, thank you very much. Let me get my slides up. Well, thanks very much, and thanks for the opportunity to talk about psychiatric advanced directives. We've had some terrific discussions so far, and my perspective on this, so what I'll be talking about a little bit is sort of panning out and taking a national view of what's going on with psychiatric advanced directives, and particularly how to make them effective. We've have tremendous enthusiasm at this conference, which is great to see, about how psychiatric advanced directives can empower choice. But the question we've been working on is, so how do you make them take effect in mental health systems? And how do you get them to be an important part of decision-making in the day-to-day lives of people who are affected? So I'm going to talk just briefly about that and recognize that one piece of the equation is drafting them, getting them prepared so that the process that goes into creating a psychiatric advanced directive, and we'll talk about that a little bit. And then you have the step of putting them in a place that someone will find them. So putting them in a registry or an electronic record or giving them to your provider. And then the process by which the provider recognizes that they should be activated, that they should be put into use, retrieving them and getting their colleagues to respect them and to use them. And so this whole process, which we call the transmitter-receiver problem, has to be thought about in order to make them effective. And it's great to see the enthusiasm we have today. Let's think about the other steps in this process. Now, one thing to think about is, well, where did PADS come from to start with? And they really came from back in the around 1990, when Nancy Krzan, who was medically ill, she had been in a car accident and was in a persistent vegetative state, and her family wanted to remove her from life support, and Mississippi wouldn't authorize it. Because they said, well, how do we have proof, or how do we know that, as the parents said, that Ms. Krzan would not want to be living like this on life support? And when it went to the Supreme Court's decision was, yes, people do have a right to self-determination and to decide what they should do with their bodies, but there needs to be clear and convincing evidence of a person's wish to be withdrawn from life-sustaining medical treatment. And this is where the whole idea of written advanced directives came from. And soon thereafter, back in the time when Congress actually enacted legislation, they passed the Patient Self-Determination Act of 1991, which really stimulated the implementation of medical advanced directives or living wills. And it created a federal law that hospitals receiving federal funds, one, ask patients if they have advanced directives, two, document advanced directives and follow them, and have written policies for implementing them. So this was a very significant piece of legislation, because it's the reason why, if any of you have been in a hospital since 1991, why they ask you if you have an advanced directive, and usually are pretty vigorous about trying to find that advanced directive. So advocates, after the mental health advocates, after the passage of this law, began to think about adapting advance directives for mental health purposes with the hopes of strengthening patient self-determination and reducing the use of involuntary commitment, because so many times when a person can't speak for themselves coherently, the alternative that providers seek out is involuntary commitment. But psychiatric advance directives generally differ from end-of-life advance directives in that most statutes set aside psychiatric advance directive statutes are what's called self-binding. And that is that once the person has been deemed to be incapacitated, and so once the provider, usually a psychiatrist or psychologist in some states, determines that the person is incapable, unable to make and communicate health care decisions, the provider documents in the chart this person's incapacitated, and then the PAD takes effect, and the person cannot change his or her mind about their treatment plan or what they have documented in their PAD until they become capable again. So most of the statutes in the country have this self-binding aspect, although there are a few in which that's not the case. For example, in the state of Washington, the consumer has the option of making their PAD binding or not binding when they complete their PADs. So in the late 90s, states started passing standalone PAD statutes. And in North Carolina, where I'm from, ours is really two pieces of legislation. There's the advance instructions, or what would be equivalent to the living will, and then there's the healthcare power of attorney, by which someone can appoint a trusted person to serve as a proxy or to make decisions for them during the period of time that they've been determined to be incapable. Just a note on the incapacity issue. It's different than being declared incompetent. Incompetency is when a judge hears testimony about a person's ability to make decisions for themselves and appoints a guardian, or in your case, might not be a guardian, but appoints that person to make decisions for them. Incapacity is a bedside determination. It's a clinical determination in which it's written in the medical record that the person's not able currently to make decisions, and that someone else, a proxy, should step in your case, a conservatorship. But the important thing here is think of this healthcare power of attorney as sort of a temporary or emergent form of conservatorship. And the great advantage of it is that it's a two-way street. So many times guardianship or conservatorship is a one-way street. The one's appointed a guardian or conservator, and it usually lasts indefinitely and is hard to reverse. So this is sort of a way to have a temporary conservatorship or guardianship. So where are we with states that have passed these statutes? Just to be clear, you can still write a PAD in any state, even if they don't have a set-aside PAD statute, and then you just would write your PAD within the medical advance directive healthcare power of attorney sections. You don't have to live in a state that has a PAD statute. But let's see where we are. Since the early 90s, when this all started, you see that we now have 27 states that have these standalone PAD statutes. So most recently in Nevada in 2017. But you see, this is the progression of states that, by dint of the advocacy of folks like you, have passed these statutes in these varying states. So we now have 27 states that have these special PAD statutes. But just to be clear, in the remaining states, you can still execute something that looks very much like a PAD. It just is in the format of a medical advance directive, but it can have the same effect. So one of the questions out there, and maybe I don't have to say that at this conference where there's so much enthusiasm, but policymakers do ask, do consumers really want to complete pads? Do they care about them? Would they want to do them? And so we were involved in a survey with the MacArthur Research Network on Mandated Community Treatment. And we did a survey at these 5 sites: Chicago, Durham, San Francisco, Durham, North Carolina, San Francisco, Tampa, and Worcester, Massachusetts. And we asked 1,011 persons seeking care in these clinics, have you completed a mental health advanced instruction or appointed a healthcare agent for future treatment? And you see that there was a very low rate of completion, really about 4 to 5%. There was one outlier in Tampa, but on average, we'd say about 4 to 5% of people have completed them on their own. So if you looked at that, you'd say, gee, there's really not much interest in psychiatric advanced directives. There's low rate of completion. But then we asked, would you want to complete a PAD if someone helped you to do it? So if there was assistance available, would you want to do it? And there we found that about 2/3 to 75% of people said, yes, if someone could help me and help me figure out how to do it and help me complete all the steps, I surely would like to do it. And in fact, in our research studies since then, we consistently have found that when you offer people assistance in completing them, that about 2/3 to 3/4 go ahead when offered assistance to complete them. So that's really good news, but it also indicates there's a big latent demand. There's a big difference between who actually has completed one and the number of people that would like to complete that. And that's important because in order to get attention to psychiatric advanced directives so they become part of the practice of providers and health systems, we really need to have more of them out there so that providers learn about them, get to use them, get into the habit of finding them when there's a crisis, and so on and so forth. So we have thought that it's a very important step to develop ways to give assistance to consumers who are interested in completing PADs. So another question is, well, do federal payers and does the federal government support PADs? And in fact, they do. This goes back some years, but during the rulemaking on seclusion and restraint in psychiatric facilities, the Center for Medicare and Medicaid Services said really very clearly that one of the aspects of the patient's rights in hospital settings is to have psychiatric advanced directives, to formulate them and have them respected. And the significance of this is it is a condition of participation for hospitals. And what that means, what that jargon means, is that if you want to bill Medicare or Medicaid and you're a service that does bill them, then you have to respect not only the other rights that people have in institutions, but have the right respect people's psychiatric advanced directives and implement them. So the feds went on record with this in 2006 and later reinforced this in making it a quality metric for psychiatric facilities. So the federal government is very strongly saying that they support psychiatric advanced directives and that hospitals and other clinics with taking federal assistance who run afoul of this could lose their funding. So we have been interested in what kind of help can we give consumers in completing them so that when folks draft them, they'll be satisfied with what's in them and they'll be respected and found when needed. And so we did a series of studies. First, we showed that we can develop a facilitation technique so that people can complete an advanced directive with a little bit of help, and that the completed advanced directive comports with what they really want. And so we first found that research assistants can do it, but then we also found that clinicians and peer support specialists and volunteers from NAMI could do it as well. So we found that there is a way to do this that's not too difficult. It's just a process, a systematic process of going through the pads, and that it's very successful. And we consistently come up with completion rates of about 2/3 to 3/4 when we ask people if they'd like help with them. One of the lessons we learned along the way is often these are going to be read in very busy crisis facilities. And so while we encourage people to put into them anything they want to as sort of additional information, we do encourage people to keep them simple. So when we were doing our studies, we were trying to find people that had psychiatric advanced directives. We found several people who had done them. And this is an example of one that someone has done. And what it illustrates is that there's just too much stuff here. There's also conflicting information if you drill down into it. And most people we showed this to, at least providers, they kind of said, well, I couldn't get through this and really put it into action. There's just too much stuff here. And so when we facilitate them, we try to keep them simple. And we say for each instruction, like in terms of medication, say what are the medications you would like and what are the medications you wouldn't like, and try to give a rationale, because it helps the provider to know where the consumer is coming from when they complete a pad, and that they have rational reasons for making these choices. We also problem solve and reality test with people so that we try, we don't want people to write advanced directives that they're going to be unsatisfied with or that don't reflect reality. For example, when we have them pick a healthcare power of attorney, we have them pick several people they trust, because we want them to recognize that the person that they would like most to facilitate it, the treatment might not be available that day. So pick alternatives. And similarly, make choices and ask for things that are relatively realistic, because we don't want you to lose faith in the pad, nor be disappointed in them. So that's the facilitation that we've been doing. We also have a project in North Carolina called the Crisis Navigation Project, in which we are training peer support specialists and NAMI volunteers to learn our facilitation project, learn how pads work, and to reach out and provide local clinics across North Carolina so that people can get their pads completed. And we think this is a really important step, that there be networks of you can refer people to when they want a pad. And I think, from the work you're doing in California, it seems like you're well on your way about this, but it's really important to have referral networks of people who will complete pads, excuse me, and reach out to consumers and say, hey, this is something that might help you. And so this project in North Carolina has been very gratifying, because we have a lot of volunteers who are reaching out to folks who might want them and getting them completed. So I'm just going to wrap up here and just tell you a few of the things that we have found. One, I told you, is that there's a large latent demand but low completion of psychiatric advanced directives in most public clinics, and that to make them effective and to create public awareness, we have to have the same kind of momentum you've seen around medical advanced directives. You've seen this thing about the conversation, about 5 wishes, we need to have the same momentum in the mental health community as there is in the medical community for end-of-life directives, so that there's a lot out there and there's a public conversation going on about the need for this and how it can assist in substituting for involuntary care and for guardianship. But we also need to recognize that patients or consumers do face significant barriers to PAD completion, that most people need help because the documents themselves are very legalistic, hard to understand. It's not always easy to find witnesses and notaries if you need this, or to figure out how to put them in a place that they'll be stored and retrieved. We found that facilitation or technique that people can use to help consumers really can help complete PADs. And that we found that in that process, the PADs that are created tend to be useful and to conform to what consumers want and are accepted by clinicians. That when they're done carefully and thoughtfully and recognizes sort of the parameters of the mental health system, it helps. For example, if you only put down one hospital you're willing to go to, what if that hospital is free? You're not going to get what you want. So we try to also write the PAD so that they have options for providers to follow to still respect the consumer's choice. So I'm going to stop there. If you want to hear more about PADs or get more information, we direct a national resource center on psychiatric advanced directives at nrcpad.org. And we'd love to hear from you there, see all our information in each state. But if you want to get other information, you can go to NAMI, to this crisis navigation project, to the Bazelon Center on Mental Health Law and Mental Health America. They all support PADs and all have very useful information. So thanks very much for having me. And if you want to contact me, you can contact me at marvin.swartz@duke.edu or contact me through the National Resource Center. And again, thanks for the opportunity to talk to you today.